I want to introduce our specialty first, because most of you probably have never heard about what oral and maxillofacial surgery is, right? It's a very, very small specialty. In fact, in Germany, we have about 600 specialists in this area. And I think the United States is much bigger, but not that much bigger. So in fact, I think you already pointed out, and I actually went to Wikipedia because they know everything, as we know. And I thought, let's see what they say about an oral maxillofacial surgeon. And actually, I think they're coming pretty close. So it's a specialty that involves dentistry and medicine. So most of us have at least a dental degree. So you can become an oral maxillofacial surgeon by going through a training program that is based on dental school. But people who do more and more comprehensive surgery mostly have a double degree, just like me. So we do dental school, medical school, and then, in my case, if you stay in a university, you also do a big research project and do a PhD, and then you become a professor, and then you do a residency and whatnot. So altogether, it takes about 14 years, and my husband always said, you never want to work, you only want to study. I've reached that working, place about 20 years ago now, and now I'm sort of trying to wind down, which is not easy. So anyway, like I said, doctor of medicine or doctor of dental surgery. So what do we do? So you see this young woman, and this is really the topic of our conversation or my talk tonight. We really change. I think it's not so much that we do surgery. I really feel I change people's lives, and that's really why I love doing this. And I get excited if people are happy about what we can do for them. So this is a young woman who grew up like that for 16 years. And can you imagine if you had a deformity like that and you were in school, what would happen to you? I think you will have friends, but I know that she probably had to suffer a lot of bullying or something like that, right? So this is how we helped her. So it takes about 3.5 hours, and of course a lot of pain and suffering for the patients with swelling and whatnot. But basically in a half a day of work, actual on the patient in the operating room, we can make huge changes in their facial expressions or in their face. And to this day, I get patients who come to me years later, and they come back and they say, you changed my life. I still remember this one young man who basically came to the office and wouldn't look up, and he wouldn't he wouldn't let anybody of the family take any pictures of him. And then he said, I'm going to Edinburgh after the surgery. So he went as a student abroad, and I saw him 4 years later, and he came back, and he was a different person. He had really bloomed, and he was smiling, looking people into the eye, and this is really, I have to say, this is really what drives me and what I love about my specialty, and I want to share with you how we do it today. So another thing that oral maxillofacial surgeons do, which is I just wanted to sort of give you a little bit of the scope as well. We help people with cancer where you have to make a new jaw, and we actually take the part from the leg and put it up in the jaw. This is one of the things, and you probably also heard about the face transplants that are now being done. And I think right now in the world there are somewhere in between 10 and 20 face transplants that have been done, and this is sort of the new frontier. And as oral maxillofacial surgeons, we are also involved in building the underlying structure. This is a young man who had a very bad injury, a burn, and this is what he looks like after a surgery like that. Of course, this is sort of the forefront of medicine and surgery right now, and our specialty, oral maxillofacial surgery, is also participating in that, in building the dental and jaw part of it. So as you can see, there are things that are much more complex than what I do. But I want to talk a little bit to you about how I can make something like this happen that you see here on the upper right side. So the simplest way, or not maybe the simplest way, but the traditional way of doing that is really what we call orthognathic surgery. You maybe heard, you can see that ortho is, if you go to a person who gives you braces, as an orthodontist, and the orthognathic surgery is the same sort of Greek background. And it basically means that we can do surgery on the jaw and we can make it right. And so we do that, as in this young woman, in one setting. And basically what we do is we move, within the surgery, we move the upper and the lower jaw around. This was actually invented about 30 years ago in Germany, actually Switzerland, by a professor by the name of Hugo Apfelgeser, and I trained with one of his scholars, one of his students. And at that time, you know, we did not have little plates or anything like that. Everything was stabilized with wires, as you can see, all of these wires in there. Yeah, and still from that time, the first thing that people who come to my clinic ask me, do we get wired shut? And no, we don't anymore. I've been saying this for 20 years and people still ask me that question. Yeah, so we don't have to wire shut anymore. This is something that was in the very beginning, 30 years ago, when Dr. Apfelgeser invented this procedure. Today, it's very different. The surgical procedure is still the same. So everything is done from the inside. If you have this surgery and you saw the young woman before, you don't have any outside scars. Yeah, we don't even have to go through the skin. We don't have to do anything. Everything goes through the mouth. It's a little bit like working in a hole, but you know, we are all trained in doing that. And we can basically make cuts in the lower jaw, as you can see here. Yeah, we basically make sagittal cuts on the lower jaw in both areas where the wisdom teeth are, and you can see that it's called a bilateral sagittal split because we split sagittally here. Yeah, and then basically we can move the tooth-bearing part of the lower jaw, we can move that forward and backward. And we can also move it up and down a little bit. Yeah, and then in the upper jaw, what we can do, we can detach the tooth-bearing fragment of the maxilla. We can detach that from the face and again move that back and forth, and then we can basically put it into a new position. So in the last 20 years, I would say, there's really been a revolution in oral maxillofacial surgery. And the revolution is that we now have these kinds of images. So whenever I send my patient now to get a CT scan, I get a little movie back. Yeah? And the other thing that you can see here are these little plates. And these little plates really mean we don't have to wire anybody shut anymore because they are stable enough that right after surgery you can open and close. You cannot eat a steak or an apple. Yeah? You have to eat something that is very soft, that you can basically squish with your fingers, like mac and cheese or ice cream or something like that. Yeah? But you can eat. Yeah, and we do not have to wire you shut. You just have to be very careful because the bone has to heal afterwards. So these are really the two major things that happened in the last 20 years in oral maxillofacial surgery, especially in jaw surgery. So again, you know, this is another example of what we can achieve within one surgery. So this is a young man, and you can see he's not quite as dramatic, but he has a very long face. And I don't know whether it's very apparent, but you can see up there that the young man, his upper teeth are behind his lower teeth. And if you have a normal bite, and you can basically feel it in your own dentition, your upper teeth should be in front of your lower teeth. Yeah, and the orthodontists can do a lot. Yeah, they can move the teeth around, but if the discrepancy is so big that they would have to move the teeth out of the jaw, then you need jaw surgery. Yeah, so in his case, and also for his long face, you know, we did jaw surgery for him, and this is himself about 3 weeks later. You can see here on the right side, we don't use any wires, but we give our patients little rubber bands that they can use to rest their jaw when they're not eating or speaking or something like that. You can see that he overdid that a little bit because he tried to be really careful. Usually I recommend you only put one on one side and one on the other side, but he tried to be very diligent and basically put a lot in, but he can take them out and put them in himself. Yeah, so we do recommend that your jaw is resting most of the time when you're having jaw surgery in the first couple of weeks, but you can open and close and you can eat. Yeah, and we also recommend if you want to speak or something like that, then you take them out. Yeah, so I don't want people to move against the jaw. But here you can see now, after the surgery, again, that was about 3.5 hour, 4.5 hour surgery, that his upper teeth are now in front of his lower teeth, and he still has to have a little bit of orthodontics, maybe a couple of months, and then the braces are taken off, and he has a completely new bite, and as you can also see, a completely new face. So, this is what we call orthognathic or jaw surgery. Yeah, this is sort of the standard methodology that we use these days. And as I said before, you know, the imaging and the plating has really revolutionized the field because within a couple of hours we can make people functional with a complete new bite and a completely new appearance as well. And I always talk to my patients that really they are involved in deciding, you know, what they want to look like afterwards. Yeah, sometimes I'm joking and say, you know, Brad Pitt or Angelina Jolie. Of course, we can't make that happen. Yeah, but, with everybody at least. And but you know, you can move the lower jaw and the upper jaw in directions. So I show you later, we do simulations for our patients so that they can sort of see what they would look like afterwards. So, but I want to stick to surgical technique a little bit. So another thing that we're doing is distraction osteogenesis. So what does that mean? Distraction, yeah, you pull something, yeah, and osteogenesis is the bone is growing. So it's basically growing bone by gently pulling on the bone. And how does this work? This was actually invented many years ago by a Russian surgeon, orthopedic surgeon, who was working with kids who had one leg too short. Yeah, and basically he developed these devices, and you can see that here. And interestingly enough, what he found, if you make a cut in the bone, in a living bone, and you pull it apart 1 millimeter a day, the bone will grow new bone in between the two cuts. Yeah, so you're basically growing new bone. If you pull too fast, it doesn't work, then you get a scar. And if you don't pull enough, then it basically fuses again, like a fracture. So you have to pretty much exactly pull 1 millimeter a day and pull it apart, and then you have a viable but soft bone in between, and this bone becomes a new jaw. Yeah, so and so that's how you can. And the same principle you can also use, for example, for the lower jaw. Yeah, so we have these what we call distractors, as you can see here. These are the blue devices, and on the left side you can see there's a cut there. Yeah, and then we do the distraction vector, the DV. Yeah, we want to move the lower jaw a little bit forward because you can see there's a big gap between the front teeth in the upper jaw and the lower jaw. And so you gently pull like 1 millimeter a day, and the red part that you can see here is the new bone that is forming. And that is a very successful method that is mostly applied in children who have very severe craniofacial deformities, who are born with very small jaws or not very discrepancy in the jaw growth. And but we can also use it in adults. Yeah, so for example, a patient who is asymmetrical in the face, you can distract one side and then basically bring that patient into equilibrium. And this is one of those, one of the examples. This is again one of my patients. She had a deviation of her lower jaw. Her right side was a little bit different from the left side, and we combined an upper jaw surgery with a distraction in the lower jaw, and that's what she looks like afterwards. Yeah, and I think symmetry is something very important in the facial aesthetics as well. So and the distraction osteogenesis takes a little bit longer, but it's actually, from many perspectives, much more gentle than doing a real jaw surgery. Yeah, because you only have to make one cut, and then you basically put the distractor on and just pull. Yeah. So the same thing you can do, for example, in the upper jaw. This person obviously has an upper jaw that's really very far back. Yeah, and especially in kids with cleft lip and palate, that is a problem. We also do not only want to move the upper jaw, the bone forward, but we also have restrictions in terms of the scarring from all the cleft surgeries. It's very difficult to move the jaw forward because the scars hold things back. And we can actually do the distraction osteogenesis to do that for them. I wanted to introduce a patient here who had an acromegaly. So all of a sudden, when he got older, he had a tumor that made his jaw grow. And you can see here his face. Yeah, he's actually a colleague, a periodontist. And he opted for distraction osteogenesis because we had to really move his upper jaw, his midface, almost 15 millimeters forward, and that is a lot. Yeah, so we put the distractor on, and then let me see, where is he here? Why is that not moving? I'm sorry. Sorry about that. My slides don't move forwards. So I have to, let me see. For some reason the slides didn't move forward, but that's what he looked like afterwards. And you can see the distractor here that we've been using for that. And we basically just put the distractor on and made a couple of cuts, and then we turned the distractor slowly for 15 days and left it in for a little bit longer, and his surgery was over. Yeah, so we didn't have to do any major surgery. We just had to do some cuts, put the distractors on, and move everything forward. So that is one of the possibilities. So this is sort of the second way of doing corrective jaw surgery. And then there's a third way that unfortunately only works in children. And it's based upon the fact that in children, all the sutures in the face and in the cranium are not fused at that point. Yeah, up to 14 years, you actually have a lot of sutures in your face and in your head that are not fused completely. So if you put something, for example, like in this case, if you put an orthodontic face mask on there, and we knew that for a long time, yeah, you can make corrections, because if you pull on the whole jaw, you know, the jaw and the growth will follow the pattern, the pull of these distractors. Of course, as you can see, you know, no 12-year-old wants to go to school like that, right? So, yeah, so there was actually an ingenious invention by a Dutch orthodontist who basically said, you know, we can correct, and you can see this little girl also, she has, again, a very flat mid-face, and if you look in her mouth, you will see that her upper jaw is too far backwards, and so she's about 11 years old. And what Dr. de Klerk did, he just put some little plates on there, you know, see in the lower jaw and also in the upper jaw, and he put some rubber bands in between, and just started pulling the upper jaw forward, and that's called orthodontic distraction. Yeah, and you can see the same kid a couple of months later, you know, because her sutures are open, really these little plates that she has here, and you can see them coming out of the gums here and here, and she was just wearing some rubber bands in between these two little plates, and because her sutures are open, and the pull of the rubber bands really pulled her whole midface out. Yeah, so I think we're going more and more now into the direction, if we see a child like that, instead of later doing jaw surgery or distraction osteogenesis, we actually do this right away when they are still little. Yeah, because it's very minimally invasive. And you can see here, this is actually a CT scan of a child like that, and what you can see here is that this is the original position, the red one, and then you can see here the gray, that is the new position of the midface. Yeah, you can see that just with this pulling of the rubber bands and these two little plates that she has on the upper and the lower jaw, you can move the whole midface out. Yeah, so one of the newer tendencies is now that when we see children that we do not wait until they are 16 years old and we operate on them once all the sutures are fused, but we do that very early on. Yeah, so I think, you know, we're moving the field forward in this direction. Yeah, so, and this, of course, doesn't involve very much surgery at all. It's really just that you put under local anesthesia or sedation 2 plates here and 2 plates here, put some rubber bands, they basically wear it all the time, and after a year, in most cases, the deformity is corrected. Yeah. So, this is really sort of from the surgical technique point of view. Yeah, but I think most of the patients who come to me do not only want to have their bite corrected, and you saw that in the first case that I saw there. In many cases, it's really the bite, but in many cases, it's also that people have such severe deformities that they simply also want to have a different facial aesthetics. Yeah, and so that is also very important for me. That's one of the things that I really like, is sort of trying to figure out, you know, if I move the jaw in this direction or the other direction, what is a great aesthetic for a person? What do they look like afterwards? I mean, there are some ways that we can sort of, you know, predict, or where we can say, well, you know, these are some measurements that we can take to predict whether a face is aesthetically pleasing or not, and this is really not new. Yeah, if you've seen pictures by Dürer for him, for example, here in the 15th century or 16th century, yeah, he already said, you know, one of the measurements is that basically this height and this height and this height always has to be 1/3. Yeah, that's sort of the ideal measurements. And that's still true today. And sort of a version of that, this is what we do. Yeah, so we actually take these very elaborate measurements, which are, you know, they look newer than what Dürer was doing, but it's really essentially the same. We're taking measurements in the face. And you know, all of these number columns on the left side, which you never have to bother with, but I do, yeah, basically tell me whether the upper jaw is too far backwards, the lower jaw is too far forward, the angulation of the teeth, yeah, and it's all basically compared to a relative norm. Yeah, and if I look at all these numbers on the left side, I know what's wrong and what needs to be corrected. So for every patient, we do this kind of analysis. And really the 3.5 surgery, believe me, is only the tip of the iceberg. Every single one of these cases is a lot of preparation in order to get things perfect. And then, in the past, what we used to do these plaster models, and then we put them in this thing with this contraption that's called an articulator, and then I would actually go into the lab with my saw, and saw these models apart, and you can see here I saw them apart and then move them forward, glue them together to plan the occlusion and the surgery. So that is something that is now behind us. I do everything computer modeling now and computer-based, and I'll show you how it's done today. As I said, we can also, based on the x-rays and photos of patients, so if a patient comes to me and said, can you tell me show me what I'm going to look like afterwards? So we have programs where we can basically show the patient what they look like before and after. Of course, these are approximations, and the question is always, what happens if I cannot deliver? Yeah, I promised somebody will look like that, and then they come out of surgery and it looks slightly different. So I always make sure that to say, it's an approximation, but I think in many cases it's very helpful, because it's very difficult to imagine what you will look like if you have this surgery afterwards. And I think the visual impression is very important. So this is something that we do routinely, but this is only 2D. And I'll show you later what we do now in research and development with 3D. So the difficulties is really that these simulations are 2D and we're looking at a 3D problem, right? So if somebody like this young woman has, not only one jaw is too short and she has a very short chin and things like that, how can you show her what she will look like afterwards when a lot of her aesthetics is also from the front, And we can only do the simulations from the side and 3D. So again, whenever we do the x-rays now, we get these really nice movies and we can actually go through them and look in detail what the problem is, which was not possible 20 years ago or 25 years ago when I started, and now I'm outing myself in terms of my age. So the other thing is I get a lot of patients who have sleep apnea. You probably heard about that. And some of them, like this gentleman, also have what's called a class 2 malformation, where the lower jaw is too small. And the question is always, and you can see here that his upper teeth are very far in advance of the lower teeth. So he basically also needs, just for his bite, he needs this surgery, not only for the sleep apnea. But the question is really in these kind of situations, you can see he barely has an airway. Right, and he's sitting right now. So what do you think happens when he sleeps, when he lies down at night, preferably on his back? I mean, he's going to be awake in a second again because there's no air going in there. So, but the question is really, how much do we have to move his lower jaw forward in order to open up the airway? We really don't have a good measure for that. And what happens right now is really that basically patients get one size fits all. So. Everybody is moved forward 10 or 50 millimeters because we really don't have a good prediction whether maybe just 5 millimeters would be enough. So this is also something that we're working on. We want to see how we can simulate the movements of the lower jaw and simulate the effect on the airway so that we know, maybe one person only needs 8 millimeters, right? And it's also an aesthetic problem, right? I mean, if you move the upper and the lower jaw 50 millimeters forward, we look like our relatives in the jungle, right? So and that's so that's something that I personally don't like. So but the other revolution really, and that's coming back to the two revolutions in our maxillofacial surgery, is that we can now take these 3D X-rays and we can also take 3D scans of the outside jaw, and then we can put them on top of each other, and I will show you that we can actually now on the computer simulate all these things. So this is also a young man with sleep apnea. And we can use these 3D images not only to simulate in 3D the bone changes, but also the facial changes of the patient. And really what we're using more and more is really virtual reality, or augmented reality in our planning methods. The easiest thing is that we do simulations on our desktop. And, but we can also do things like that where we can actually fly. Where we can actually fly through go into a picture and fly through it. I think it just takes a little bit. My computer, here we go. Yeah, so basically on your screen now with a cursor, you can go and fly into a picture. Yeah, so you can have a level of immersion, what you couldn't do. You know, when I started, we had two-dimensional X-rays, and you know, we didn't get that kind of imaging or visualization. And then, of course, based on these images, what we can do, we can virtually cut the bone, yeah, and basically put everything back together again in the way we want to put that together. So all of this planning can now be done on the computer. So let me see whether we can get this going here as well. Yeah, so this is a little kid, and you can see he doesn't have any sutures. So he has what's called craniosynostosis. Yeah, and basically what we do, we take the whole skull apart and then put it together again. And usually we used to go into the operating room and just start cutting. And now basically we take the X-ray and cut it virtually and then put it back together again. Yeah. So how does that apply to our maxillofacial surgery and to jaw surgery? So basically, all my cases now, I don't go back to the lab and saw anything anymore. I basically take X-rays, these 3D X-rays, and then also pictures of the patients, just like here. Yeah, and of course, we do the clinical examination and so on and so forth. And CBCT scan is a special scan, and also the 3D surface imaging. And then we put it together, and we send it to a company, and they come back with this kind of model for me. So I make a sort of what we are doing today, like a webinar session with them or a web session with them, and you know, I go over the planning with the technician, and so we're looking at you know, what the original situation is, and then of course I had all my measurements and I have an idea of where I need to move the jaw. So I tell the technician, you know, cut the upper jaw, move it up a little bit, like in this case you can see here, we move the upper jaw up a little bit, and then we cut the lower jaw and adjust it to it. And then, you know, we get these really good pictures, and I can see how much I need to move forward. I basically get the whole surgical plan with all the millimeters, and I can see in 3D how I have to move the jaws in the surgery, which is really amazing. This is a huge step forward from doing like plaster models and 2D photography and wires. Yeah, so, and I also can see here down in the lower jaw very nicely where the nerve is, which I want to avoid during the surgery. And here's another picture of, you know, the nerve in the lower jaw, which is very important in these procedures, so that we know how we can avoid it. And then the company, basically with a you know, printing mechanism, they make these surgical splints for me, and I go into surgery and I can exactly reproduce what I planned on the computer. Yeah, so this is much more precise than what we used to do many years ago. Yeah, so that's why we're now doing everything with computer planning and to simulate these surgeries. And we actually then take X-rays afterwards and make sure for our own quality control that what we got is what we planned. Yeah, so, and this is really amazing. And what I also talked to you, so now we can also do that dynamically. Yeah, and the next step is really that we can show it to our patients and we can move the jaw around, and then, like in this case, show them interactively what they're going to look like after the surgery if I move the upper jaw in this direction or that direction. So this would be three-dimensional, not only two-dimensional. Yeah, because now we have these surface scanners that scan the patient before the surgery, and then we can show them the same thing after the surgery, what they would look like after the virtual surgery. Yeah, and then I can go into my surgical planning system that I just showed you, and can do the same thing, so that the patient basically looks like that afterwards. Yeah. So I mean, the possibilities and are really amazing. That are the advances that we've made in the last 20 years. Actually, this is probably 10 years. You know, the same is true for, we're close to simulating also the maxillomandibular advancements for sleep apnea. Again, you see here the airway. This is not quite as bad as the patient that I showed you before, but we can simulate to move the lower jaw forward and simulate what the airway would look like. And now we are at the point where it may not be necessary anymore, where we to do the same thing for everybody, yeah, but we're closer to getting more individualized, personalized surgical plans for patients, where we see in one patient maybe we just need to move 5 millimeters, and the other patient we need to move 10 millimeters forward in order to get an airway opening. And you know, there's already some you know, research on that you know, for sleep apnea with virtual planning, the results are actually improved. So this is what we're doing right now. So this was the past, the present, and what's going to happen in the future. Yeah, so you know, we're in Silicon Valley, and I'm just starting to collaborate with a company who they make surgical robots. So maybe you don't need me anymore in 20 years from now. So there is a surgical robotic company that makes a robot that's called the Da Vinci. And I was just there in their lab a couple of weeks ago, and we started doing you know, facial contouring surgery with a robot. And it was absolutely amazing. I mean, I'm completely fascinated. So who is the surgeon on this picture? Where is the surgeon sitting, do you know? Yeah, they could be in another room, but you know, they're not here. Yeah, that's the surgeon. and that's the surgeon actually. Yeah, so you sit at a console far removed from the operating table, and it's like a video game. And do you know that do you have kids? Sure. So there's actually research now that young surgeons who do video games are much better than the older ones like us. So yeah, so you know, if your kids play video games, encourage them. They could become really good surgeons. So I thought there was yeah. So my son was happy about that. So you know, I mean, the robot is of course directed at this point by a surgeon. Yeah, but you know, all the laparoscopic surgery, like you know, taking out gallbladders and all that kind of stuff, that is largely done with can be done with robots these days. Yeah, and it's truly, I mean, I was sitting there, it was kind of remote, as if I was flying a plane, and the robot over there was cutting the bone for me, and you know, taking all the soft tissues away, and I was just like, whoa, this is amazing. Yeah, so, yeah, and it feels more like a game. It's really, really strange, but you know, we're already there, and you know, it will come, and it is already in, if you go to Stanford, I don't know how many Da Vincis we already have. Yeah, and really the wonderful thing is that a robot is very precise. Yeah, you can control the movements very, very subtly, much more even than the human hand, I think. And you know, and in some areas, like if you have to work in the belly or something like that, you just put the ports in there, and you don't have to make any big cuts anymore. That's amazing. And the same thing would be true for us, because we could go, you know, underneath the skin and make these cuts, and don't even have to take a lot of soft tissue away anymore to get to it. Yeah, so we will work. We'll start. We are on our way. So the other thing is really augmented reality. Yeah, and I don't know whether you've seen all these glasses now. You know, Facebook bought this company, and everybody's talking about augmented or virtual reality. And you can see the same thing in the surgical field, right? You know, it could be that you're wearing these glasses, and you're basically in the operating room, and all your pictures, your anatomy is overlaid virtually for you over your patient. This is actually my husband. I think that's why you're smiling over there. Right? He is an electrical engineer here at Stanford, and he does virtual reality. So he gave me this picture. And because I don't have these glasses, but he does, right? And we actually tried Google Glass in the OR as well, and things like that. So, you know, it would be fantastic if I look at a patient that I do not only see the patient, but also the X-ray at the same time, right? So right now we're using surgical navigation systems that are relatively clumsy, but, you know, these kind of glasses, I could see wearing that. And you know, I actually looked a little bit around the internet, and so there is this video there. This is sort of what I'm envisioning, right? Take my iPad, go to the operating room, hold it over your face, and then I know exactly, yeah, I see the anatomy there, and I know exactly where I need to cut, right? Yeah, so, you know, this stuff is already in the works, and, you know, this being Silicon Valley, at some point we are going to be there. Yeah, so the surgeon knows exactly where he needs to go with this little thing. Yeah, and you know, if we even take it a step further, you know, you're wearing smart contact lenses, not even glasses, and so this person is looking into the fridge and sees, oh, the cucumber has low calories, right? So then you get your food out. What I really liked about it, and I think the connection to surgery is, you know, here you have, imagine this is a bone, right? And it has little lines on it, and you just have to cut where your glasses tell you to cut. Yeah, so, you know, like I said, maybe you don't need me anymore in 20 years. Yeah, so this is really what's happening on the very far sort of frontier of surgery. So after I took you on a ride here in the future, yeah, and you know, this is something that personally fascinates me, and I try to participate in that because, you know, we are Stanford, we want to move the world forward. And you know, I think what I try to tell you in this brief talk is that you know, we've made amazing progress in surgery, in surgery, in our maxillofacial surgery, really because of the imaging we have now, the computer planning we have now, and the minimally invasive procedures like distraction osteogenesis or distraction. And also the little plates that we can use that allow you to open your jaw. We don't have to wire anybody shut anymore. I repeat it again after 20 years. So, and then, you know, we can influence facial growth with like little kids who have deformities. We can just put plates on and pull on it and create and basically correct deformities. And we can grow bone by gently pulling it in with distraction osteogenesis so that we don't have to do any big surgeries anymore. So I think this is really sort of what's happening right now, what we can do right now. And but for me personally, again, you know, the biggest important matter is this is one of my patients who came to me, and this is, you know, I put her pre-op photo in her family photo that she showed me yesterday, and she had sleep apnea, and she had jaw deformity a little bit, and she was always tired, and of course she sent me this airbrush picture afterwards, and you know, the most important thing for me is that my patients are happy and that I can help them with their lives. Thank you.
If the deviation of the face, especially lower jaw, is because of mild CP that the child had it's more of neuromuscular issue, rather bone deviation was secondary to that. So what would we do for that?
Can you repeat the question again? I'm sorry.
You know,
yeah.
If the deviation of the lower jaw was because of the weakness of one side of the face,
Yes.
because the child had, you know, just a little bit of CP,
Right.
cerebral palsy.
Yeah.
So it's the issue is more of neuromuscular problem rather bone. Bone is secondary to the whatever weakness he had. So what do you do for that?
Well, in these cases, you would still have to correct the bone because you cannot correct the bone by making any changes to the muscle, right? So you still, if you wanted to correct it, you would still have to do a jaw surgery if it's necessary. You know, it is not always necessary, and then you could correct it. By the time they are grown, if you're fully grown, you cannot make any changes to the bone anymore by, for example, you know, one of these more or less invasive methods. That's too late. However, when it was at an earlier stage, you could probably influence it with either with orthodontics or distraction. So it really depends on the age. So.
I came to know early, but you know, he did orthodoncy, but we didn't get the result we were looking for that. So that's why I thought maybe because I didn't have the information of, you know, before age 14, and he didn't show it much before age 12, 13. So gradually when he became mature, then it showed it even more.
But you can still, I mean, you could still correct it by doing corrective bone surgery or jaw surgery,
Thank you.
and that would stay, so.
Curious with the osteogenesis, do you go in and basically turn a screw to make the gap bigger so the bone grows, or can the parent do it, or what's that process?
The parent or the patient do it. We help them initially, and then they can do it. Yeah, it's actually like a simple screw that you turn around. Yeah, it doesn't hurt. Yeah.
So the underbite, the jaw surgery, nowadays a new technique is you do not wire at all.
No.
Then how, I mean, it has to be healed. You can, I mean, you don't really chew or anything, but it has to be stabilized at least a couple of weeks. What I understood is that, you know, your mouth cannot move at all.
Well, no,
only
it can
liquid
move.
diet.
No, you can actually move. Yeah, because these little plates that we put in stabilize the jaw in the new position, and they're stable enough for open and closing. But the food has to be very soft. Yeah, and usually we recommend that you start with a liquid diet and then you move on to a soft diet.
My neighbor, he was over, but he's a bigger, tougher jaw. Anyway, he had a surgery 2 years ago. I think that it was at Stanford, but my understanding, he was actually mouth shut for at least 3 to 4 weeks. Only food was like a squirt into the syringe or something like that. He was actually mouth, according to mom, I saw him too, but it was done about a year and a half ago. So this whole technique has started, how long ago was not?
15 years ago.
Really? Wow. So you never really mouth shut wiring?
No, I don't wire anybody shut. It's not necessary. It's if
how
people,
severe it is?
It doesn't matter. Yeah, I mean, as long as you have the plates, they keep everything in place. It's not a problem. Yeah, so the plates keep everything in the new position. Yeah,
And it takes a long time though, since it's a bone.
Yeah,
it takes like
about
4 to 6 weeks.
Correct. Yes.
And so that is a very good news. I guess it's for your shot, and you cannot talk. You cannot, many things you cannot do, especially eating.
Yeah, you can eat, and the only thing we use is little rubber bands, and we encourage the patients to wear them as much as possible. But they can take them out themselves to eat and speak. Yeah.
How soon after the surgery?
They can do that right after the surgery if they wanted to. Yeah. In fact, many people I don't, because if somebody feels claustrophobic, we're even having rubber bands. And if they tell me before the surgery, I let them wake up without any rubber bands, and then we put them in before they go home.
But if you move, then the healing is interrupted?
No,
Healing is
no, because the plates keep the bone in a stable position, even though it's like when you have a fracture, right? When you break your leg, right? The reason why we put plates on everything is that you can function immediately. Yeah, and that's the same thing with the jaw. There's no difference. And if people are, if people are still wired or closed for many weeks, then it's mostly because the surgeon doesn't trust the plate. Yeah, so you have to be careful, but you can open immediately.
So your patient, for instance, like more severe case, how long healing process the day of the surgery to how long that, how do you call it, without the wire, but becomes a kind of normal life is how many weeks?
It's just like it's just like a fracture when you break a leg or a jaw or something like that. The whole process until the jaw is completely like it was before takes about 3 months. Yeah, but the plates will actually take the load while the bone is not fused. Yeah, so and that is the reason why we put plates everything, so that you can open and close immediately and nothing happens.
Okay, for your patient, statistically, a person who has sleep apnea is the actual main reason try to have the surgery done. I mean, that's a really big reason. What percentage of the statistically, how successful? I mean, I can afterwards don't have to use a CPAP machine. That's very successful. Is there some data showing?
So the bimaxillary advancement surgery is the most successful surgery to do that. But it also depends on what you start with, how bad your sleep apnea is. Yeah. So not everybody can be completely healed with that. And that depends on the individual situation and the individual patient. There is no, you cannot really say something for everybody. Yeah.
So
Okay.
when you see the patient evaluating, you can almost say
Yeah.
this is a successful case. It is not, it may not be
Right.
100%
Yeah,
good.
that
You
is
can-
that is
you
very
can, by
important.
looking at all the
Correct. Yes.
examination
Yes.
and looking at the chart and all that, you can
That's
tell
correct.
pretty much.
Yeah, you can put it into a ballpark. Yeah.
We have
Thank
another question.
Yeah, sure. Hmm.
So I promised my daughter I'd ask this question. She said her jaw is clicking, and I wondered if that's sort of serious or not. And also, I have been diagnosed with sleep apnea, and I wondered, you say something about moving the top of the jaw as well as the bottom?
Yeah, you in sleep apnea you have to move both jaws, right? Because if you only move the lower jaw forward, your bite will get disturbed, right? So you have to move both jaws forward. That is the simple answer to the question about sleep apnea. The clicking in the joint is usually in correlation with the temporomandibular joint, and that is something that needs to be assessed in the individual situation. You know, it has different reasons, and the clinical examination will show what the problem is. Yeah. So it's good to maybe talk to a TMJ specialist who can actually temporomandibular joint specialist. These are dentists this is the joint that's called the temporomandibular joint. Yeah, temple, mandible. Yeah, it's the junction up here, and there is actually, it's just like in the knee, there's a little meniscus, and that can jump back and forth, and you know, it depends on how it jumps and all those kind of things. So there are specialty dentists who do nothing but that, and they can take a look at that and also recommend what to do. Yeah. Mm-hmm.
The plates come out, the stabilizing plates come out later, or they stay there?
So we can leave them in. Yeah, they're made out of titanium, just like dental implants, and they actually fuse with the bone. However, that said, I have a lot of young women who are very slender. Yeah, and sometimes they don't like the feeling of them, and also when the bone remodels, the plates might be sticking out a little bit after 6 months, and then we just offer them to take them out. And that's a small surgery. But they could stay in, and many people decide not to take them out. Yeah. Yeah. Okay.
Any other questions for Dr. Giroux?
For the sleep apnea version of the surgery, is it like stabilizing plates both for the upper and the lower
Yes.
jaw, or you have to wear some kind of mask?
No, it's stabilizing plates for the upper and the lower jaw. Yeah.
And you
Yeah.
make cuts in both upper and lower jaws?
Yeah, but from the inside again.
From the
Yeah,
inside.
underneath the lip. Yeah.
And the jaw will protrude or will go back.
For sleep apnea, you want to move it forward. Yeah, so that the airway is opened up.
So that aesthetic issue won't be there. So
Yes, there is an aesthetic issue. Yes. Yeah. But not necessarily for everybody. Yeah, it depends on what you start out with. Yeah. So.
Any other questions? One more back here.
How far beyond Stanford have some of these techniques traveled? If I were to be in Omaha or someplace else, would I be able to find a facial surgeon or a dentist who might be able to perform either the sleep apnea or the repair for the child's face?
It depends. I think the university hospitals usually have specialists with sort of this education. Yeah, but probably you won't find it that often. Yeah, and so the sleep surgery field was really developed here by some Stanford surgeons who are still working at Stanford. So. And you know, more and more people are going into that field, but you know, I think, and I also don't know how much of the computer, you know, simulation and these kinds of things, these kinds of advanced techniques you would find. But certainly, you know, jaw surgery is something that our maxillofacial surgeons all over the country can do. Yeah,
Are any of these techniques covered by insurance yet?
they are all covered by medical insurance. If it's a functional issue, the medical insurance covers the surgery. Yes.
has telemedicine started for this, you know?
Excuse me?
Telemedicine. Let's say you're doing operation here
Uh-huh.
at Stanford, you can guide somebody in different state or different country, or you contribute. Because at UCSF, they kind of do certain things by telemedicine.
Yeah, so I think that is a very good question. I think with surgery, I think the delay time of really doing surgery by having the console here and you know the patient in Africa is I think, as far as I can tell, and I'm not an engineer, is not feasible yet because of the delay time. And you also, of course, want to have people nearby who know what to do when the telemedicine or the telesurgery wouldn't work, right? So that is an impediment. But we are reaching out through, you know, surgeon education and empowering people by fellowships and courses that we teach to acquire these skills so that they can go back to their home countries and actually do these surgeries comfortably. And I'm involved in a very big foundation who does about 600 courses like that every year. Yeah, so we go all the way, everywhere in the world. Yeah, yeah.
So the Da Vinci robot at this point, does that allow remote surgery or not yet?
I
Like
don't think so.
if delay is not a problem.
I don't think so. It's in the same operating room. Yeah.
One more question.
Is there a reason why the insurance company is requiring that the tongue be moved before they're willing to deal with the severe sleep apnea?
The tongue?
They're wanting the tongue moved first. Why? Instead of having it as part of the whole surgery.
Oh, the uvula.
The
palate?
tongue.
The tongue?
You remember Shauna? It's Shauna.
Yeah.
We're still fighting the insurance company.
I cannot
That's what
tell you
they're
why
insisting
they are insisting on that. That's beyond me. Sorry, insurance companies are not my specialty, and I don't want I don't want to be a specialist. Sorry. Yeah.
Does one have to have a dental referral to see you for a consultation?
No, a medical referral. We don't take any medical insurance, any dental insurance at Stanford. And everything I do is covered under medical. Okay. Yeah, that's why I don't do any teeth and things like that. So.
Sure.
Yeah.
So first the patient should go to a surgeon, then would be referred to you?
No, the primary care physician can do the referral. Yeah.
Thanks.
Yeah.
Any other questions? Well, thank you, Dr. Giroux.
Yeah. Oh, thank you for listening.